Thank you for taking the time to listen to this presentation about the recent European LeukemiaNet recommendations for managing chronic myeloid leukemia that was presented at the 2025 conference of the European Hematology Association. And many thanks to the ICMLF for making this recording possible. So just to give you a little bit of background, after you've seen my disclosures, which, as you might imagine, relate to companies that make tyrosine kinase inhibitors, the European LeukemiaNet has been producing recommendations for the management of CML since 2006, and there have been 4 sets of recommendations over 2006 to 2020. So this is the 5th iteration of those recommendations. And it's important to understand that because it's important to understand how we go about developing the next set of recommendations. The first thing to say, I guess, is that I am joined in this recommendation paper by 37 other physicians who are expert in the management of chronic myeloid leukemia. That's not to say there aren't many other physicians around the world who are equally expert, but this is the group that has grown within the ELN. And when we start to create the next set of recommendations, which we do when we feel that there has been enough published evidence since the last set to make it important to modify, introduce, or change our previous recommendations, we first get the panel members to read the last set. In this case, it was in 2020, and identify any areas which they feel are in need of updating, or in fact, where there has been completely new data that ought to be included. And as we develop those areas and we develop the topics that we think ought to be changed, we develop a series of questions concerning the definitions and the management and the side effects, etc. And they get circulated and returned. And if we get 75% consensus from the panel about a way of thinking of this new evidence, we accept that. If we don't get 75%, we take a careful look at the questions, because sometimes it's, as you can see from the answers, it's because the questions haven't been worded correctly, or whether there's some possibility of different interpretation of the question. So we try and refine the questions until we get consensus about something that we would publish. Now, actually, we didn't get consensus, and in the past we haven't got consensus on some issues. And if that happens, we just mention it in the manuscript and explain why we didn't get consensus. And I've got one very good example of that in a moment. The questions and the emailing are backed up by in-person hybrid meetings, which you can see listed there. And in this particular occasion, there were 7 of them. And as I say, where we can't get consensus, we will discuss those issues in the text. So these are the topics that are included in this version of the recommendations. I am not going to go through every one of them because that would take a very long time. But what I am going to do for you is to pick out some of these areas and show you either where there was controversy or where we have changed or introduced something new. So I think the first thing to do is to mention disease classification, which is not a completely new issue to any of us. And the reason is because although most of the trials of the tyrosine kinase inhibitors have used the definition of the disease phases in CML according to the ELN, the previous ELN recommendations, these have differed for a long time from the recommendations that are published in the Blue Book of the World Health Organization. And in particular, I'm not showing chronic phase because by definition, it's anything that isn't accelerated or blast crisis. So if you see that one big issue was that the definition of accelerated phase in terms of the number of blasts that would define a patient in accelerated phase was different in the two classifications. And almost more importantly, I guess, is that the definition of blast phase was different, with ELN requiring more than 30% blasts and WHO requiring more than 20% blasts. And then there was this debate about whether additional chromosomal abnormalities present at diagnosis were significant. I think we all agree that chromosomal changes evolving on treatment suggest progression, but what do they mean when they're present at diagnosis? So in 2022, the WHO redefined disease phase in CML, and actually they abolished accelerated phase, and they defined CML as a biphasic disease, and that involved losing accelerated phase, accepting blasts greater than 20% as blast crisis. Anything less than 20% is still chronic phase, and you can see that extramedullary disease or the presence of lymphoblasts would put the patient in the category of blast phase. Now, this is controversial, and we did not achieve a consensus within the ELN expert group. The reason why WHO went in this direction is that there's very good genetic evidence suggesting that CML is a biphasic disease. If you do gene expression profiling, originally came from Jerry Radich many years ago, there was a very distinct difference between chronic phase and blast phase, and patients in accelerated phase look very like blast phase. So it didn't look genetically that there were three different phases. Almost in contrast to that, if you have a patient presenting in accelerated phase, according to either definition, you're normally going to treat them with the tyrosine kinase inhibitor alone, and actually the majority of them do exactly as patients in chronic phase. So there must be something in the definition, the old definition of accelerated phase, that doesn't quite make sense. And there's a nice study showing that patients who present with 20 to 30% blasts, who would be accelerated phase in ELN, but blast phase in the WHO, have outcomes more similar to blast crisis. So maybe allowing patients with up to 30% blast to be called accelerated phase is inappropriate. The prognostic impact of additional chromosomal abnormalities at diagnosis remains less clear than those emerging on treatment, and the WHO wanted to align blast phase definition with the definition of acute myeloid leukemia. Against changing the disease classification is that people felt that this was a dismissal of a very long-standing and very well understood definition. For patients who present in the accelerated phase, which may no longer exist, it identifies those who might benefit from a more potent tyrosine kinase inhibitor up front. There was a feeling that there would be an inability to study accelerated phase as an entity in future studies, although I must say that in the majority of big centers, patients with accelerated phase are rather rare these days. So actually it would take a very long time to do a trial in accelerated phase. So personally, I'm not so sure about that one. But there is, of course, an inability to compare the results from new studies with the results from earlier observations if you start changing the definitions. So we acknowledge this in the text. We could not reach a consensus, and you are free to use whichever definition you wish. And that is important in some countries where drugs are approved for chronic phase, but not for accelerated phase or blast crisis, and vice versa. However, the WHO, if you read the small print, actually acknowledges that there are patients who at diagnosis are already at much higher risk of progression. So they include high ELTS score, this business of percentage of blasts. So in chronic phase, those with more than 10% up to 20%. More than 20% basophils in the peripheral blood, and these additional chromosomal abnormalities, and the histopathological observation of clusters of megakaryocytes. They all indicate an individual who you might want to be more aggressive with the TKI, use a second or third generation if you can at diagnosis. Not that there's any proof that this makes very much difference, but it seems like a sensible thing to do. And they also recognized that features that emerge on treatment, such as a failure to achieve hematological response on your first TKI, resistance to two sequential tyrosine kinase inhibitors unless there's an obvious kinase domain mutation, the development of new chromosomal abnormalities, or the complex or the occurrence of complex mutations in BCR-ABL, all indicate patients who are going in the wrong direction. And this is important because it means either you will probably want them on the most potent TKI that you have available, and you might want already to start looking for a potential transplant donor if that's an option. So let's turn now to prognosis. And we often introduce talks these days on CML, particularly when we're teaching, saying, because we emphasize the amazing change that tyrosine kinase inhibitors have made, by saying that for the majority of patients, their life expectancy is now that of an unaffected member of the normal population. That's not, it's true, but it's not completely true. And we always quote a paper from the Swedish Cancer Registry when we say those things. But most recently, there's been another paper from the Swedish Cancer Registry, which shows that actually there is a small loss of life expectancy for patients with CML. And I'll try and explain these slides. So the top is the loss of life expectancy. And that is for men and for women. And this is the quality adjusted life expectancy change. So this is the, sorry, not very well explained. This is the number of years that are lost, and this is the proportion of your life that you would lose. So obviously, if you're diagnosed when you're 85, probably having CML doesn't make very much difference to you. But if you're diagnosed when you're 45, this is the number of years that are lost to you. On average, about 6, sorry. And similarly for men and for women, and this is the proportion of life that you potentially could lose if you're diagnosed. So it means that we are not completely there with curing CML, or at least returning it to a chronic disease compatible with the normal life expectancy. There are patients that at diagnosis have features that would suggest they're at very high risk of progression, and they are not going to get a normal life expectancy. So what did we think these features were? Well, we believe that the European long-term survival score should now replace so-called Hasford and Euro. And if the patient is a high ELTS score, they're at higher risk of progression. And the presence of these additional chromosomal abnormalities at diagnosis indicates somebody that's at higher risk of progression. And it's important because it may determine your choice of TKI. What is much less clear, and we didn't reach consensus about including them in the paper, is the role of the transcript type, whether the patient has an E13A2 or E14A2, because many of the papers that have shown that there is a delay in achieving certain response levels, molecular response levels, are probably affected by the fact that the actual assay to measure these is less efficient for E14A2 than it is for E13A2. So it's probably a technical abnormality. What is much less easy to explain is why patients with E14A2 seem to have a better chance of successful treatment-free remission. So there is something in the transcript type, but it's not firm enough to be able to suggest that we should be thinking of changing the TKI. So the other thing that is not controversial, in fact, the panel we're in complete consensus about this, but it does bother everybody, is the increasing amount of information that suggests that somatic mutations in genes other than BCR-ABL, which is about 20 to 30% of all patients, but it's much more common in high-risk chronic phase, accelerated phase, blast crisis, So we're talking about ASXL1, RUNX1, Icarus, etc. There is increasing evidence, but at the moment it's basically a research tool. It seems in the papers to have an impact on depth of response and event-free survival, but until recently, nothing on overall survival. Most of the data comes out of labs that have focused on extreme responders, so taking excellent responders and comparing the proportion of patients that have somatic mutations in those with the proportion in patients who are clear failures, and showing a difference. But actually, we don't know what happens to the vast majority of patients who fall into the middle zone, so who weren't completely optimal responders, but certainly weren't resistant patients. So introducing a change in management for on the basis of extreme responders doesn't make much sense. A lot of the studies did not confirm that the mutation they were seeing was in the CML cells because they didn't have a control with unaffected cells. It could just be chips, of course. And unfortunately, at the moment, there's no obvious therapeutic implication. So you can't say, oh, my patient has an ASXL1, so they should start asciminib as first line, for instance. And the data for that comes out of the Australian group, who looked at the achievement of major molecular response, failure-free survival, and the chance of developing kinase domain mutations on the basis of whether patients had or had not somatic mutations. So you'll see that the black is no somatic mutation, the red is the presence of an ASXL1, and the blue is the presence of another one, such as RUNX1. Now, the important thing about this paper that was presented at ASH last year is that this is 315 newly diagnosed patients from Australia treated with either a second generation drug upfront, or indeed it includes 99 patients who were in the ASCEND study who received asciminib upfront. And you can see that even with the use of a very potent drug in first line, the presence of ASXL1 still seems to confer an increased risk of developing a kinase domain mutation, an increased risk of failure-free survival, and a less chance of achieving a major molecular response. So even with the most potent drug at the moment, it's a problem. So you have no therapeutic avenue to go to when you find this. And I think we just need lots and lots more information. Now, one of the big controversies, which took a while to settle, and we did reach a consensus, which is a very good thing, is the famous milestone table. You'll know the molecular responses at 3, 6, and 12 months. So in trying to reach a consensus, we constantly had to remind ourselves what we were trying to achieve. The recommendations were applicable worldwide to both expert and non-expert physicians. I mean, there are some people in the UK who may only have 2 or 3 patients with CML in their clinic. And what we want to do with those patients and the recommendations is to be as safe as possible. So the goal of the recommendations is to prevent or delay progression to blast phase, because that's what will improve survival. So it's important to try and recognize patients who aren't doing very well, or as we've just seen, who are worrying from the moment of diagnosis, because you might treat those differently. And in contrast to that, of course, it would be good to identify patients who are suitable for treatment-free remission. And I feel very strongly about this because I don't think we should be giving false hope to people who probably are never going to get a trial of discontinuation, but it's also good to recognize those who might. So what have we done with the famous milestone table? Well, the first thing we've done is we've changed the terminology a little bit. So instead of optimal, we have favorable, and instead of failure, we have unfavorable. And that was largely prompted by the patient advocacy voice, who don't like to be called resistant, understandably. I mean, it's not the patient who's not resistant who failed. It's not the patient who fails. It's the drug that fails. But we tend to talk about failing patients, which is not a very nice thing to say. So the optimal or favorable indicates that the development of resistance is very unlikely and that treatment switches are probably going to be unnecessary unless the patient is intolerant. So they remain exactly the same. The warning area remains the same. So this means that resistance is possible but not probable. A treatment switch may become necessary, and those definitions are exactly the same. The changes come slightly with the unfavorable. So this was the previous failing group. So the development of resistance is highly likely. And instead of saying the treatment switch is mandatory, we are saying the treatment switch is the preferred option. Why are we saying that? So you may remember in the previous definition, we suggested you change the treatment if the patient was still not in complete cytogenetic response at 12 months. And now we agree that that's a very good indication for a patient who's likely to develop resistance. But for patients who are between 1% and 10%, we have introduced some details in the text to suggest a way of management. Why have we done this? It started with a paper from MD Anderson a couple of years ago, who described 131 patients who had failed to achieve major molecular remission in 2 years. Now, you need to be very clear about this because major molecular remission was never a definition of failure or unfavorable response. So it's a slightly different cohort of patients. But the point of this paper was that they had this group of 131 patients, and they were in a variety of responses at 2 years. So some were in complete cytogenetic response, some were in major cytogenetic response, which generally means an RQ-PCR of 1 to 10%, and a proportion were over 10%. Now, the over 10% is clearly not a good situation at 2 years because of the 15 patients who progressed, 11 of them were in that category. So that's not a good situation. I think we'd all agree with that. But what they were trying to say, I think, is that quite a lot of this 131, so let's say 80 of 130, eventually achieved a better response. So they achieved major molecular response, 79 achieved a major molecular response, 24 went into complete cytogenetic response, and there were a small number, so a total of 28, who didn't get a PCR under 10%. And when they looked at the progression-free survival and the CML-related survival, you can see that CCYR is red, major cytogenetic response, so 1 to 10% PCR is blue, and over 10% is black. So for progression-free survival, the patient spread out, as you would expect. But when you looked at CML-related survival, over 10% in black was obviously bad, but there wasn't very much difference. In fact, you could say no difference between patients who were under 1% or 1 to 10% at 2 years. So patients who were in this situation may have been dying, but they weren't dying of CML. Now, what that then happened is that prompted a landmark analysis of the German CML4 study. Now, the German CML4 study is an old study. It started around about 2004, and it was a randomization of various doses of imatinib with or without the addition of interferon or Ara-C, and a total of 1,600 patients were entered into this study. Now, at the time, as you can imagine, not everybody had PCRs every 3 months. So what they did is they went back and they identified patients who had a PCR at least one of the time points, 3, 6, 12, or 24 months. And you can see that there are around about 850-ish patients in each group. It's important to know that they aren't the same patients. So these 805 patients aren't the patients at 6, 12, or 24 months, but you took whoever had a PCR at the time. And then you look to see who was over 10% at those time points, and you can see very clearly that although about 28% were over 10% at 3 months with imatinib, which we would understand because that's what's come out of most of the first-line studies, most of these patients did respond with the PCR under 10% as time goes on. So it's an issue of how important this over 10% at 3 months is, because some patients are just slow to respond, maybe because they've had to stop the drug for intolerance, maybe they've had a dose reduction. However, being over 10% at 12 months is not so good news, and certainly not very good news at 24 months, but I'll come to the details in a moment. So this is a study of the outcome in terms of survival probability, whether patients were under or over 10% at 12 months. And I think actually this vindicates the recommendations that have been in place for a long time. It's not very good news to be over 10% at 12 months. But I think we've all accepted that because the milestone table is over 10% at 6 months. And if I showed you each individual curve, you would see that they also separate at 6 months. The 1% is slightly trickier. I mean, I would say that those two curves split, and that if you're over 1% at 12 months, it's not such a good position. And I would recommend that in the majority of patients that you should switch the drug. But if we then look at the outcome by age, we see a slightly different picture. So these are the patients who are under 60, and the blue and the green are under 1% or 1 to 10% at 12 months. And the lower line is more than 10%. And you can see in the under 60s that the curves separate. Now, if you look at the over 60s, you would say the same thing, that the curves separate. But what you immediately notice is that the survival is not as good as the under 60s, which I think you would expect in an older population. But the difficulty here is that none of the patients who were between under 1% or 1 to 10% died of CML. They were dying of other comorbidities. And that introduced the question of, if you're over 1% at 12 months and you're older and you have pre-existing comorbidities, maybe changing the drug to a more potent drug that might exacerbate your comorbidities or introduce new side effects is not in your best interests. But this is a very individual decision. So we did not want to remove the milestone of more or less than 1% at 12 months. And we did not want to introduce a particular age at which you should be altering your management. This is to be an individual situation because there are many people over 60 without any comorbidities who, if they're over 1% at 12 months, should probably switch their drug. The other thing is that people start to look at these tables as though the recommendations are written in stone. No TKI switch should be made on a single PCR result. You should look at the trend. So as I say in many talks, if your patient was 86% at diagnosis and they're 11% at 3 months, you don't have to change the drug. They're heading in a very good direction. But if they were 15% at diagnosis and they're 16% at 3 months, they're not responding to that drug at all. So look at the trend as well as the actual result. As shown by both studies, some patients in the previous failure category are simply late responders, and some of them are older, have comorbidities, and may not do well with the more potent drug. And also be careful that you are not changing the drug simply because you want to get the patient to TFR. Think about whether they're really a candidate for TFR. And again, we have a little bit of evidence. This paper here shows that if you look at the result at 3 months, so more than 10%, less than 10%, less than 1%, and you look at the chance of having a deep molecular response, so MR4 or greater, at 24, 36, or 48 months, it's much, much higher if you were under 1% at 12 months. So if you were an optimal responder, you are much more likely to get yourself into the situation where you may be offered a chance of TFR. And if you were over 10%, although it's not absolute, you may achieve MR4 at some point, it's much less likely. So changing the drug in somebody who's an unfavorable responder to get a TFR probably isn't the right course of action. And then there's a nice paper that was presented at ASH again from the German Population Registry, and they looked at the attempts of TFR in patients who were optimal responders, and you can see that it was about a quarter of the patients, and those who didn't reach the milestones, it was less than 5%. So probably the majority of patients who are going to achieve TFR are those who are favorable responders in the first 12 months. The other thing which has come out recently, which is very interesting, is that Efficaci et al. Have produced the quality of life data from the Euroski study. You may remember the Euroski study was the biggest stopping study run in many countries. So there were about 720 patients included in that study, and many of them filled out quality of life at the time of stopping and then after stopping. And you would imagine that people feel better off their TKIs, but what you can see if it's divided by age, and it's green for under 40s, blue for 40 to 60, light blue 60 to 70, and the pink for more than 70, is that actually there isn't much change in physical functioning in any of the age groups, but actually it's a lot worse in the older patient, which I suppose is just anno domini, right? They're not going to get physically better with age just because they've stopped their TKI. But the ability to function, the role functioning, how you go about your daily living, was only really better in the patients under 40. It was not better in older patients. So trying to get an older patient to TFR because they'll be better off the drug doesn't look like it's actually going to happen. I mean, age is age, and as you get older, you get less fit. Now, the next topic was first-line treatment, and the reason that this is important, of course, is because of the introduction of asciminib and the fact that asciminib now is licensed in many countries for first-line treatment. It's not the role of the expert group to tell you which drug to use. The licensing in each country and the availability of the drugs in each country is different. So all we would say is that all 5 TKI look pretty good in terms of keeping your patient fit. Multiple studies have confirmed that the achievement of certain responses is faster with second-generation drugs, but none of them as yet have showed a benefit in overall survival. The Japanese ran the study that we all wanted to do, which was a comparison of dasatinib and nilotinib up front, and showed no difference in any of the parameters you might want to measure. We've had a couple of studies now that have added interferon to the tyrosine kinase inhibitor in first line. Most recently, the Tiger study from the Germans. There's a modest benefit in achievement of molecular endpoints, but all these benefits are offset by increased toxicity. So we don't feel there's a role for addition of interferon at diagnosis. And we discuss in some detail the dosing, because you will know that probably some of the drugs were licensed at the wrong dose. Maybe imatinib should have been licensed at 600, maybe dasatinib should have been licensed at 50. So we discuss in some detail, and you can read it in the paper about the dosing. Now, of course, first-line treatment, there are 5 drugs available, and obviously there is the addition of the myristoyl pocket inhibitors. The only one licensed at the moment is asciminib, but there are 2 other drugs going into clinical trial. These contrast with the ATP competitive TKIs, all of the ones you know. Ridotinib is licensed in Korea, and olverembatinib is the Chinese drug that's going into clinical trial in the rest of the world. Now, what about asciminib? I think it's worth thinking a little bit about asciminib, because there's increasing amounts of data from the first-line study. Now, these were presented at ASH again last December. It's a complicated study because patients were randomized to asciminib or essentially investigator's choice, and then if the investigator's choice was imatinib, they became a separate group. And if the investigator's choice was a second-generation drug, they were combined together as a 2G TKI. So we had results presented at 48 weeks, a year, and at 96 weeks, 2 years. This is asciminib versus all other drugs, and you can see that asciminib outperforms in terms of the primary endpoint, which was major molecular remission, outperforms any other drug, both at 48 and 96 weeks. Differences are getting probably about the same at both points. It clearly outperforms imatinib, which is what you'd expect. So big difference in MMR at those 2 time points. But the jury was out at 12 months as whether the responses were better compared to second generation agents. But at 2 years, it seems to be slightly in favor of asciminib. So asciminib looks to be a highly effective drug. It's not available to everybody. It may well be a very appropriate second or third line choice. One reason that it looks very attractive is that if you look at the side effects in this study and you look at the grade 3 or greater, and you look at the adverse events leading to discontinuation or adverse events that lead to interruption or adjustment of dose, it all looks like asciminib outperforms imatinib or the second generation drugs. So it's coming, and we wait further evidence, but we have not made a recommendation that that should be your drug of choice. As I said before, your choice of first-line treatment does depend a little bit on your aim. Is it a patient where you want to delay progression, or is it a patient that you would really like to see treatment-free remission? You're going to take into account the prognostic features, which we've discussed, the comorbidities, which we've discussed, and the affordability and the availability of each drug. We have a table in the text about if your patient develops a mutation, a BCR-ABL1 mutation, then which drug you should think about using. You'll be familiar with a lot of these, but what you might not be so familiar with is the number of mutations that are affecting asciminib and the other myristor pocket inhibitors. So these have all been described in the clinical trials of asciminib. And if your patient is on asciminib and develops one of these, you need to go back to an ATP competitive TKI. And if they've exhausted those, you probably need to go to transplant. What you might not be, might be a bit surprised about is that there are kinase domain, the ATP binding site kinase domain mutations that confer resistance to asciminib. So M244V, which was never really a big problem because it was a sort of semi-resistant to the normal TKIs, does confer resistance to asciminib, and it's a structural change that does it. And the F317 and the T315A are also resistant to a number of drugs. So you, in particular, F317 is not, I'm sorry, I've made a mistake. That bar should be against the F359. So the F359 confers resistance to asciminib. I apologize about that. The other thing you ought to know is that if the second common exon of ABL, the A2, is missing because your patient has an atypical transcript, so typically E13A3 or E14A3, they're not going to respond to asciminib because it needs a structure contained within the second exon to work. If we look at treatment-free remission, little has changed from the previous version. There is a decrease in the frequency of monitoring, so essentially 2 monthly for the first year. After month 12, 3 to 6 monthly. This obviously depends on the actual level. If the level is very low, you can extend the duration of monitoring. If it starts to change, you should do the monitoring more with increased frequency. Loss of MMR remains the trigger for restarting. There's probably no need to confirm this because you've probably been recording a steady trend of increase. Loss of major molecular response after 2 years has been reported in up to 14% of patients, so you do need to keep on with lifelong monitoring. The risk of recurrence directly into blast phase has been well described, but is probably a vanishingly rare occurrence at less than 1%. And we have introduced the ability to stop treatment in patients with atypical transcripts if you have the appropriate technology in your laboratory to monitor this accurately. Parenting. So we've spent a little bit of time in the text on parenting because this is an increasingly common question for management in women who would like to have children. Now, the first situation is the situation in which the woman it develops CML in their pregnancy. So that's a very clumsy way of putting it, but they haven't got CML when they become pregnant. They go for their first blood tests, and unfortunately, they're diagnosed with CML. So the diagnosis of CML in pregnancy. In a very nice paper from the ELN group last year with Ekaterina Chelisheva, first author, which described 86 patients who presented with CML in their pregnancy. And there's a lot of detail in the paper, which I won't go into, but if you look at how we manage these patients in the 2 decades, 2001 to 11, 2012 to 2022, you can see that we allow far more women these days to carry the pregnancy and go into labor than we did in the early years. Lots of people were still recommending termination. Now we try very hard not to do that unless it's the patient's choice. The other change we see over the decades is that the proportion of patients receiving treatment during their pregnancy is much higher. Of course, most of this treatment is interferon, which is the orange, but increasingly, is the pale blue, but increasingly, with very good evidence, it seems that imatinib and probably nilotinib are safe, definitely in the 3rd trimester, but probably also in the 2nd, because the bad effects seem to be occurring during organogenesis, which is usually completed by week 16 of gestation. So we're getting much better at being confident in letting women carry their baby to term. Now, the more common situation is the woman who has CML, is on treatment, but would like to have a child. And I'm not going to go into these for purposes of time, because you can see there's a lot of text on these slides. But these are the tables that are lifted from the paper. And so if you have a patient in this situation, I would encourage you to look at these details. It relates to the molecular response at the time of wanting to have a child or becoming pregnant. Some of them are planned, some of them are unplanned, and the recommendations of what you can do in these particular situations. This is for patients who are not yet pregnant but are thinking about becoming pregnant. And this is the patient who has become pregnant, but again, divided according to their response at the time they become pregnant and the time in the pregnancy. So divided not in the top one, but in the 1st trimester and after the 2nd trimester. As I said, I'm not going to go into detail with that, but you can find it all in the paper. We also address adverse events. I'm not going to go into detail about that because we could be here for another 2 days. But what we do is we have a list of the common side effects on the different TKIs, which you can use as a reference, and also the chance of that side effect occurring on that TKI, whether it's very common or very rare. We're often asked, and we have provided this table, as to what investigations one should do at the start of a particular drug. It's divided by the investigations and by the drugs, as you can see. And then we also have another table, which is how you should monitor patients, perhaps annually, 6 to 12 monthly, on particular drugs, and which tests you should be doing against which drugs. So for imatinib, you're probably not worried about their lipids, their blood pressure, or their thyroid function, whereas with ponatinib and nilotinib, you would be. So there's a lot of detail in the paper. I hope that you will take the time to read it. Sometimes that will be when you have a patient with a particular problem, which is just fine, but hopefully we've provided really practical recommendations that personalize management for each patient. So it's only left for me to thank the members of the expert panel and also Michael Narani and Leif, who gave me some very nice slides to illustrate some of the controversial points. Thank you very much.